Hi, my name is Brittany Byers, and today I'm going to be talking about noncompliance with MMR vaccines and the increasing incidence of measles cases among the United States population. Prior to 1963, annually 3 to 4 million people were infected with an average of 550,000 reported cases, with 400 to 500 documented deaths and 48,000 hospitalizations. In 1963, the first two-dose measles vaccine was licensed, and in 1967, the number of measles cases decreased from an average of 1,000 to 200 cases per week, and incidence decreased by over 95%. In 1977, the National Childhood Immunization Initiative was enforced, as well as the implementation of the state immunization laws, causing an increase of immunization rates to almost 90%. In 1981, 96% of all school children in the United States were vaccinated. In 2000, the United States declared elimination of measles and maintained that status for almost 20 years. In 2020, COVID pandemic began and vaccination numbers began to decline. To compare 1963 to 2024, last year there was a total of 285 documented cases, with 120 of those being less than 5 years old and 89% of those being unvaccinated or unknown vaccination status. Here I provide a graph showing the reported measles cases in the U.S. from 1962 to 2023, before and after the vaccine was licensed. In healthcare, there are multiple levels of prevention. I'm going to be discussing three. Primary prevention is the first and is directed toward healthy individuals and populations who are at risk for measles. Methods for primary prevention include ways to prevent the infection and transmission of the virus. The advanced practice nurse can provide education and administer immunizations as methods of primary prevention. As an advanced practice nurse, it is important we educate the U.S. population on multiple aspects concerning measles and the MMR vaccine. Vaccine hesitancy is the large contribution to decreasing uptake of the MMR vaccinations. This is related to misinformation from social media, celebrities, anti-vax communities, and the press. This is why it's important that the advanced practice nurse educate and provide evidence disproving vaccine misinformation or myths. Topics that we can talk about include herd immunity, transmission of the virus, how easily the virus is spread, symptoms of measles, MMR vaccine dosages and revaccination, possible side effects of the MMR vaccine, and vaccination schedules. We can also provide research for disproving common misinformation, such as vaccines causing autism and no longer needing vaccines because the virus does not seem as prevalent. In later slides, I'm going to be discussing a little bit in detail of these different education topics. Measles virus is highly contagious, and approximately 90% of the susceptible individuals will become infected with measles after exposure to the virus, with a basic care reproduction number of 12 to 18, meaning 12 to 18 susceptible people can become infected just from one person. Transmission is through indirect and direct contact, as well as respiratory droplets from coughing, sneezing, and talking. The virus can also stay airborne for up to 2 hours, increasing the chances of infection. Environments for more susceptible to measles outbreaks include unvaccinated communities, countries with poor health care and low income, late winter and early spring, dry weather, and overcrowded living situation. Hosts include children under 5 years of age and adults older than 20, pregnant women, unvaccinated or partially vaccinated individuals, people with vitamin A deficiency, and those who are immunocompromised. Herd immunity is extremely important in prevention of infection in susceptible hosts who cannot get vaccinated. To have herd immunity, there needs to be at least 95% vaccination coverage of the entire population. Here I show an example of misinformation showing that 3% of 1,306 adults, 16 adults, agree that the measles vaccine is more dangerous than actually contracting measles. Measles pathophysiology and symptoms. There are 4 periods of infection, measles infection. The first is the incubation period, lasting 10 to 12 days. During this period, the infected individual is asymptomatic and the virus duplicates within the alveolar macrophages and travels to lymphoid tissue, ultimately causing viremia and affecting organs. And then 5 to 7 days later, they have a second viremia. Then the prodromal period occurs, which lasts 2 to 4 days, and this is when the infected cell travels to the epithelial cells and when we develop symptoms, including high fever, dry cough, conjunctivitis, rhinorrhea, and characteristic Koplik spots of the mucous membrane. Then is the exanthum period, which lasts 5 to 6 days, 3 to 5 days after initial symptoms, and 1 to 2 days after the Koplik spots develop, the measles rash will occur. The rash is described as a maculopapular rash that spreads in a cephalocaudal progression, and then the recovery phase occurs, which lasts 10 to 14 days, and this is when the symptoms resolve as long as there is no other complications. There are two types of measles vaccines. The first one is MMR, the second one is MMRV. Both vaccines require a total of 2 doses to achieve best level of immunity. 1 dose equals 93% effective rate, and 2 doses equals 97% effective rate. The first dose should be administered between the ages of 12 to 15 months old. Unless they're planning to travel to another country, then the infant can get the first dose between 6 and 11 months, but will need 2 more doses after their first birthday. The second dose should be administered 4 to 6 years old. If older children and adults don't show immunity, they can receive 1 to 2 more MMR doses given at least 28 days apart. The only exception with the MMR vaccine is it can only be administered up to 12 years old. Contraindications include individuals with previous allergic reactions to the first dose, pregnant women, or if they have just given birth, they need to wait at least 1 month, have a weakened immune system, if they have a medical condition that causes bleeding or bruising easily, had a recent blood transfusion, has tuberculosis, has had vaccines in the last 4 weeks, or is currently sick. Secondary prevention strategies are directed toward individuals who have or have potentially have measles. Methods for secondary prevention include early detection and treatment of the disease to reduce severity. The advanced practice nurse can perform contact tracing, symptom assessment, and testing for confirmation and provide early treatment recommendations. Contact tracing allows the advanced practice nurse to identify individuals who have been exposed. Mild symptoms of the measles virus can look like viruses such as the Epstein-Barr virus. Due to the likeness of the symptoms, lab tests are recommended for confirmation, and there are 2 types of tests, antibody testing and RNA testing. Early treatment recommendations can include isolation, rest, and drinking plenty of fluids. Post-exposure prophylaxis treatment is also an option. If within 72 hours of exposure, individual can receive the MMR vaccine, and if within 6 days of exposure, the individual can receive the immunoglobulin. Testing for the virus is very important in early detection of measles. Tests include serology testing, which is collected via blood and detects the presence of antibodies IgG and IgM. IgG indicates past immunizations or infection. IgM indicates current infection. And this is used to determine immunization status in active measles cases. Following a measles infection of an unvaccinated person, IgM antibodies appear within 1 to 4 days of the rash onset and peaks within the first week of onset. If serum is collected within 72 hours, there is a possibility of a negative result. IgG antibodies appear typically 7 to 10 days after the rash onset and peak 2 weeks after rash onset. Molecular detection is collected via throat or nasopharyngeal swabs or urine samples and detects viral measles DNA. It is used to confirm suspected measles cases and should be used first or in combination with serology testing. Following a measles infection of an unvaccinated person, the first 72 hours after rash onset is ideal timing. The cost of MMR vaccine testing depends on the individual's insurance, kind of test performed, and where it's performed. Examples of price estimates include Quest Diagnostic, which is $142, or CVS, that can be $89. Tertiary prevention strategies are directed towards individuals who have measles. Methods for tertiary prevention include attempting to reduce complications and improving life after. The advanced practitioners can do this in the clinical setting by ordering appropriate treatments for complications that arise as well as therapy is needed after. Severe symptom treatment include vitamin A infusion, IV fluids, steroids, antivirals, treatment from complications that might occur from a weakened immune system, such as intubation due to pneumonia. Common complications include eye and ear infections, bronchitis, laryngitis, croup, vomiting, and diarrhea, severe encephalitis and pneumonia, and long-term or rare includes SSPE. Potential unintended consequences of screening and weigh the benefits against potential harm. Unintended consequences of screening basically are from either having false positive or false negatives. IgM antibodies can produce a false positive in non-measles cases, and serological tests collected too soon can cause false negatives. And this is also the potential harm, causing a distrust in healthcare, whereas the benefits of the screening shows early detection, which means less chance of spreading the virus to other people, and also decreases the chances of complications. I would like to thank references such as using the CDC